about dementia. Today, we invited Professor Nagaendran Kandiah. Professor Kandiah is a senior neurologist specialized in cognitive neurology and vascular neurology. His primary research focuses on the impact of MCI and cerebral vascular disease on AD, PD, dementia, and frontotemporal dementia. He focuses on developing novel biomarkers and interventions, combining fluid biomarker, neuroimaging, and neuropsychological tests to study AD, VAD, and other related neurodegenerative disorder. He is currently the director of Dementia Research Center at the Li Gong Chen School of Medicine in Singapore and the head of the Dementia Program at the National Neuroscience Institute, NNI, in Singapore. He is actively involved in dementia-related training and services as the chair of the Southeastern Asia Consortium for Neuropsychological Research and Training. Many physicians in Southeast Asia visit Kandiah's Center for study. In addition, he is the chairman of the Clinical Practice Guidelines on Dementia for the Ministry of Health in Singapore. Professor Kandiah conducted a lot of study about CSF study in dementia and young onset dementia. Let's welcome Professor Kandiah.
Thank you, Prof, for that kind introduction. It's an honor for me to be here and share some of my work. Let me share my screen. Yes. Are you able to see my screen?
Yes.
Okay.
It's fine.
Yes. So over the next 30 minutes or so, I will talk today about fluid biomarker and neuroimaging profile of mild cognitive impairment, and mainly from a Southeast Asian perspective. I'll tell you about clinical aspects, which I'm sure all of you know, but I'll go through some of the more salient features. The pathobiology of MCI. I'll tell you about the study that is ongoing now called the BioSys study, and some neuroimaging and fluid biomarker, both blood-based and CSF-based, from a Southeast Asian cohort with MCI and dementia. Apologies, I'm just recovering from a cough, so I may have to cough in between. Okay. So as we know that, dementia does not start suddenly. It goes through this continuum of normal aging, subjective cognitive decline, mild cognitive impairment, and then dementia. And I think this is important to understand because if you think about the risk of progression, you have someone who is 65 years old, the risk of that individual developing dementia is less than 1% a year, very low risk. However, if you have someone with subjective cognitive decline, this risk increases to almost 3% a year. And if it's MCI, that this risk increases further to 12% a year. So the best window for us to actually reduce risk of dementia is if you are able to diagnose them as the MCI as the normal age state. So while we talk about biomarkers, I think the gold standard or the most important thing is still symptoms. And if you look at this diagram in the center, I think we're very familiar with the symptoms of moderate to severe stage dementia, where someone is very forgetful, unable to manage their day-to-day activities. They have delusions, hallucinations, other behavioral changes, as well as falls. But what we really need to do is to be able to detect the earlier symptoms. And here there are three groups of symptoms that I want to focus on. Number one is cognition. So this is a decline in cognition at an intra-individual level. So the patient comes and tells you that I'm not as good as a few years ago, but when you do your testing, all your tests are normal because of the ceiling effect of our current tests. But that does not mean that that person actually has does not have a deterioration. So we still need to pay attention to what the patient tells us. And if you look at the staging, so this will be a stage where what we call as transitional cognitive decline, right? Because the person already has symptoms and it is getting worse. So something that we need to pay attention to. A lot of the time, there can be errors at work, especially the younger people. They may have been committing problems at work. The supervisors may come to be aware of the symptoms, and that's why they come to see us. So again, something to remember. Language changes. Again, many studies have shown that some of the earliest cognitive deficits could be in the area of language, word finding difficulty, grammatical errors, the vocabulary shrinking. So again, these are some of the early cognitive aspects that we need to pay attention to when we are seeing patients in our clinics. Next is mood and behavior. And you now will know that we have the mild behavioral impairment construct, MBI. And people with MBI who also have MCI have a higher risk of progression to dementia. And we just published a paper to show that. And in the MBI domain, I think decreased motivation, problems with regulating your emotions, impulse discontrol, social inappropriateness, all are common symptoms. And again, we need to pay attention to these symptoms. Although they can also be common as one ages, so we need to be mindful. Is this part of dementia or is it something else that's causing the symptoms? We often neglect physical changes. So again, the frail MCI, where they have slowness of gait, reduced grip strength, a cautious gait, could again be all early features of a dementing illness. So we also need to ask them about physical symptoms and also evaluate how they walk and what is their gait like. We know from the dominantly inherited Alzheimer's network, the Diane study, time zero on the x-axis is when symptoms start to appear. But 30 years before that, there are already changes in the brain in the form of CSF A beta, CSF tau, hippocampal volumes, and so on. So again, this is a golden window, and 30 years is actually quite a long time. So as physicians, if we don't detect this stage, then I think we are not doing full service to our patients, because this is the stage where we can actually make a difference in terms of delaying the onset of dementia. Irreversible brain pathology continues to increase over time, especially when one progresses from MCI to mild dementia to moderate dementia. Most of our countries in this region are now mainly focusing on the dementia stage. But if you really want to make a difference to the patient's trajectory, what we really need to be doing is to try to detect them at the MCI stage or the subjective cognitive decline stage, so that we can then start them on interventional programs. Again, I'm sure you know all this. MCI is when when the person is not normal for age, at the same time does not meet criteria for dementia. There is cognitive decline, but function remains normal. And there are two main subtypes, the amnestic MCI and the non-amnestic MCI, which can further be divided into single domain, multi-domain, and so on. And knowing whether it's amnestic, single domain, or non-amnestic, multi-domain, I think is important for two reasons. Number one, the type of dementia that eventually develops. If you have an amnestic MCI, most of the time, the patient will go and develop Alzheimer's disease as they progress. Whereas if it's a multi-domain amnestic, can be either Alzheimer's disease or vascular dementia. Whereas if it's a multi-domain non-amnestic, then you might want to consider Lewy body dementia or vascular dementia. In the non-amnestic MCI, it's also important to recognize this because a lot of them may be related to psychiatric conditions like depression, frontotemporal dementia, again, something that may develop in these people with non-amnestic MCI. So knowing the type of MCI allows us to prognosticate what kind of dementia that the person may eventually develop. The other reason is, what is the risk of progression? We know that if one has amnestic single domain MCI or amnestic multi-domain MCI, their risk is higher. This data comes from the age code study from Germany, about 350 patients over 3 years. And you'll see that those who have an amnestic MCI or a multi-domain amnestic MCI, at the end of 3 years, almost half of them progress to develop dementia. So it's a very high risk state. At the same time, if your MCI is a non-amnestic and it is single domain, then half the time they actually go back to normal. So it really makes a difference in terms of the trajectory. So knowing the subtype of MCI is also important. From a pathophysiology perspective, there are two main types. One is the MCI due to Alzheimer's disease, and the second one is MCI due to vascular disease. From the in the MCI due to Alzheimer's disease, these are the different stages. You have stage 1, where you have the amyloid deposition, either detected through a PET scan or a CSF. And stage 2, when you have on top of amyloid deposition, you also have some neurodegeneration. And neurodegeneration can be detected using an FDG PET, fMRI, or on an MRI where you have cortical thinning or hippocampal atrophy. CSF changes such as total tau may also suggest that there's some neurodegeneration ongoing. Stage 3 is when you have amyloid deposition, neurodegeneration, and some subtle cognitive decline. This is where the patient comes and tells you that I'm not as good as before, but all your cognitive tests may still be normal. And then you develop MCI. So I think understanding this stage will also let us know what kind of biomarkers we need to do and what is their risk of progression. Now, when it comes to vascular MCI, these are usually people who have vascular risk factors, all the vascular risk factors, and then they develop blood vessel disease. This blood vessel disease can be large vessels affecting due to atherosclerosis, or the small vessels due to arteriolosclerosis, mainly related to hypertension. And because of this disease in the vessels, they then go and have brain injury. And most of the time, this is small vessel disease in the form of white matter hyperintensity, lacunes, perivascular spaces, or even microbleeds. And this is what then results in mild cognitive impairment. So this is the pathological changes that happens in someone where the MCI is due to a vascular pathology. So with that, let me share a bit more about the current ongoing study. It's called the Biomarker and Cognitive Impairment Study. And this is carried out at our center, the Dementia Research Center, Singapore. So the center was established early last year. The main vision is to identify brain diseases in Asians that result in cognitive disorders, to develop diagnostic tests for Asians, to develop management strategies to prevent dementia in Asians. And the approach we're taking is to study people who are at the very, very early stage. Some of them are normal, some of them have SED, some of them have MCI. On top of your traditional pen and paper tests, we have also developed digital tests, and we also use digital tests to evaluate their cognition and their behavior. And we are using biomedical solutions such as wearables to track their gait and so on. So this is our strategy. And the target is to recruit 2,000 subjects over a period of 3 years. After consent taking, we do a detailed neuropsychological assessment covering all the different domains. We do a full MRI, structural and functional, including perfusion imaging. And we do a full detailed blood biomarker discovery. And we have a Simoa platform where we look at A beta 40, 42, beta 181, neuroinflammatory markers, neurofilament light chain, and so on. So we do a full detailed characterization. So it's a cohort of MCI, SCD, and normal aging. Patients come from the community as well as from the tertiary clinics where doctors refer them to our center. It's a longitudinal study. It's a 5-year study with annual follow-up. The main objectives is to study the profiles of SCD and MCI in a Southeast Asian population, to evaluate the pathobiology of cognitive disorders in Southeast Asia, and also to develop intervention strategies to prevent dementia. So as of last week, this is our sample. So we're happy to note that we are almost 1/3 the way. We have now recruited 631 subjects. Out of them, 132 are cognitively normal. About 500 have cognitive impairment. Among those who have cognitive impairment, more than 2/3 have MCI. And this is worrying, right? These are people from the community and they meet criteria for MCI. Another 155 have subjective cognitive impairment. Among those with MCI, majority are amnestic, 217, and about 127 are the non-amnestic MCIs, and I'll share more data about these people. So this is the table showing the demographic and vascular risk factor profile. If you look at the MCI cohort, the mean age is about 64 years. Again, about 50% of them are males. Relatively educated. The mean education is about 13.5 years, so quite a highly educated group. But what is also worrying is the vascular risk factors. More than half of them have hypertension, more than half of them have hyperlipidemia, 15% have diabetes, and about 11% of them have a history of smoking. So again, this is the profile of the MCI individuals. And let's look at some of the findings. So we looked at them in the 4 subtypes. Among those who have amnestic MCI single domain, not surprising, their main deficit in the neuropsychological profile was episodic memory. And this is their standard deviation. Whereas in the amnestic MCI multi-domain, again, memory is the main deficit. But what is also interesting is the other second most affected domain is actually executive function. Right? So it's telling us that a lot of the frontal structures may be involved in our amnestic MCI multi-domain. In the non-amnestic group, both the single domain and multi-domain, again, we see executive function. A lot of them have impairment in executive function. Some of them also visuospatial function. So again, suggesting that in the non-amnestic population, a frontal type of disease may be highly prevalent, causing this profile of a executive function impairment. Now, how about behavior? We did the mild behavioral impairment checklist in the 4 MCI subtypes. Again, quite worrying that almost 50% of them have decreased motivation, especially in the amnestic MCI. Mood dysregulation, again, is quite common in the non-amnestic. So we are seeing quite a lot of behavioral changes. Social inappropriateness was seen in about 15 to 20% of people across the different types of MCI. So even in the very early stage of a cognitive impairment, behavioral changes are common. And as doctors, we need to be mindful that behavioral changes can be the presentation of a dementing disease. Now, moving on to the neuroimaging and fluid biomarker findings. So we did a plasma oligomeric A beta. And what is surprising is in our 4 types of MCI, only about 15 to 20% of them have amyloid positivity. So this is again very low compared to the Western literature. We are now looking at the A beta 42 to 40 ratio. And again, we are finding that only about 15% of them across the different types of MCI have amyloid positivity. So in our Southeast Asian population, the amyloid positive rate is very low. Similarly, the ApoE4, again, only about 20% in general, the different types of MCI, only about 20% of them are ApoE4 positive. In a similar Western population, we have expected at least about 45% to be ApoE4 positive. But in the Southeast Asian population, the E4 positivity is also low and amyloid positivity is also low. If you look among the E4 carriers, 36% of them were amyloid positive. Whereas among those who are E4 non-carriers, only 12% of them were amyloid positive. So there is some association between the amyloid positivity and the E4, but not a very strong association. Now, when you look at cerebral small vessel disease, this is where it is worrying. What we see is in our cohort, 94%, almost everyone has some amount of white matter disease in the brain. 93% of them have perivascular spaces. And as you know, perivascular spaces tell you that there is a bit of a leakage of the blood-brain barrier. And that may be one of the upstream mechanisms that's causing white matter hyperintensity. 32% of them have lacunes, again suggesting that small vessel occlusion is ongoing in this population. So very high burden of small vessel disease. Now, when you look at them in the category, in the group of SAD and MCI, again, we are seeing that very high proportions of people with WMH as well as lacunes. So small vessel disease seems to be a major problem in our cohort. If you look at the type of white matter disease, both periventricular and deep white matter changes are seen. And also half of them have confluent white matter disease, which I'll talk more in our subsequent slides, both in the SAD group as well as in the MCI group. We are now started doing arterial spin labeling, looking at cerebral perfusion. And what we are showing is as your WMH volume increases, the cerebral perfusion goes down. More so if you are amyloid positive, the perfusion is even lower compared to those who are amyloid negative. So there's a strong correlation between perfusion in the brain with WMH and greater correlations among those who are amyloid positive. Medial temporal lobe atrophy, again, quite common in the various subtypes of MCI. About 70 to 80% of them have medial temporal lobe atrophy. And again, suggesting that the medial temporal atrophy in these people who are amyloid negative may be related to vascular disease. On top of medial temporal lobe atrophy, we also looked at cortical thinning. And you'll see that again in the different types of MCI, already there are changes. For example, posterior cingulate atrophy in the amnestic single domain, the entorhinal cortex atrophy in the multi-domain subtypes. So again, even in this MCI stage, we are already seeing MRI changes, and these are maybe useful measures to increase the accurateness of our diagnosis. So some work from CSF. This was a cohort of about 84 patients with CSF. And the age range was mainly young onset, 53 to 68 years, and we looked at the ATN criteria. We use CSF A beta as the ratio as a marker for amyloid, and the p tau as a marker for tau. Medial temporal lobe atrophy was used as a marker for N, and we looked at WMH as a marker of cerebrovascular disease. Again, quite surprising. In our cohort, only about 1/3 were amyloid positive. 2/3 were amyloid negative, and among those who were amyloid negative, 40% of them had cerebrovascular disease as the only finding. Another interesting finding was another 34% of them had tau, even though they did not have amyloid. So these are primary tau disease in about 34% of patients, and 25% did not have tau or cerebrovascular disease. So even in our CSF findings, we are seeing that a lot of them are amyloid negative, but maybe tau positive or cerebrovascular disease positive. We had longitudinal data on these people. What we showed was if you are amyloid positive, you're going to have the greatest decline over 4 years. But the second group that showed a lot of decline were those who are amyloid negative, but cerebrovascular disease positive. So again, CVD is another important measure that will tell you about potential cognitive decline over time. Another paper that we published a few years ago was about medial temporal lobe atrophy. Often we think that when we see medial temporal lobe atrophy is due to Alzheimer's disease. What we did in the study was we had patients who were amyloid positive on CSF as well as amyloid negative on CSF. And if you look at the MTA score, both groups actually had about the same amount of medial temporal lobe atrophy. But what this shows us is even if you're amyloid negative, you can have medial temporal lobe atrophy. And in those group of patients where the amyloid was negative, their WMH score was high. And especially the confluent type of WMH was seen in 26% in those who were amyloid negative but had medial temporal lobe atrophy, but 0% here. So the main message here is MTA is not specific for amyloid. White matter disease, especially confluent type of white matter disease, confluent lesions like this could also result in medial temporal lobe atrophy. So when we see MTA in our patients, it may be related to Alzheimer's disease, but it may also be seen in patients with pure vascular dementia, even when they don't have amyloid in the brain. We went on further to look at the hippocampus, and we now looked at hippocampal subfields in about 176 patients with MCI. What we were able to show is, in these people, there are a few regions in the hippocampus, the subiculum, the CA1, the CA4, as well as the molecular layer. These regions were highly correlated to the amount of white matter disease in the brain. Now, it's also interesting, if you look at the structures that these 4 hippocampal subfields are involved in, they are involved in the memory formation, memory retrieval. And we know that these are the same type of deficits that our patients with WMH also have. They are forgetful, but they improve when you give them cueing. And that may be because of involvement of the CA1 and CA4 region. So what we hope to do is to develop this as biomarkers for predicting who with vascular MCI will go on to develop dementia. And again, we showed that even this hippocampal subfields is related to perfusion. Some of the regions that are atrophic had less perfusion. From a cognitive perspective, we published this last year. What we showed was if you have confluent WMH, the red line, over this 41-month period, those at confluent WMH, their annual drop in MMSE was -1.6 points. Whereas if you don't have confluent WMH, it was only 1.2 points. Those at confluent WMH, the risk of progression to dementia was much, much higher compared to those without confluent WMH. So not only is WMH important, knowing the type of WMH. If you have someone with only punctate lesions like this, it may not be so worrying. But if you have patients who have confluent large lesions, then they are at a higher risk of progressing to dementia. Also important to know that the risk of developing is much higher in this study that we published in 2011. If you have MCI and no white matter disease, then the risk of developing dementia was 17% a year. But if you have MCI and you also have WMH, then the risk of developing dementia was 27% a year, almost double. And both periventricular and deep subcortical, especially the deep subcortical, was significant. So confluent lesions in the deep subcortical regions definitely increases the risk of conversion from MCI to dementia, and we may want to target these people for intervention. So what is the mechanism? So when you see a punctate lesion, it just tells you that a single penetrating artery is occluded. But when you see a confluent lesion like this, it tells you that not only one artery is occluded, but consecutive arteries are being occluded. And this may be because of a multiple arteriosclerotic changes or a large plaque blocking the origin of these vessels. So again, tells us that when you see a confluent lesion, this is definitely something more serious, something that is dynamic, something that is ongoing. And we need to do something for these people in terms of reducing the risk of developing dementia. So why do people with WMH have cognitive impairment? So we looked at fMRI, resting state fMRI changes, and we published this in 2020. And what we showed was, if you have confluent WMH in the brain, there's reduced functional connectivity in the frontotemporal as well as the infrafrontal regions. And this is why executive function, processing speed becomes affected. And that is what we are seeing in our patients. A lot of them have executive impairment when they also have confluent type of WMH. This paper is currently under review. Quite an interesting finding. What we know is if you have white matter disease, that is going to cause more atrophy. If you have ApoE4 positivity, that is going to cause more brain atrophy. So that was our hypothesis. But in this study, where we have 192 patients with MCI and mild dementia, 259 normal, what we found was if you have white matter disease and you're ApoE4 negative, then you have more atrophy compared to someone who's ApoE4 positive. So that interaction is quite interesting because looks like white matter disease has a worse outcome in those who are E4 negative. And from a disease modifying perspective, I think this is important so that we can find some treatment strategies for those who are E4 negative but have white matter disease. And we also show that these people who are E4 negative having white matter disease do worse over time in terms of MMSE, do worse in time in terms of color trails too. So again, showing that the cognitive outcomes is also bad when you are E4 negative and you have small vessel disease in the brain. So the way I see vascular MCI is when you have vascular risk factors such as this, then two possible things. One is you may develop large vessel disease due to atherosclerosis, or you may develop small vessel disease. Now, what is the mechanism of small vessel disease? I believe it's an interplay between blood-brain barrier dysfunction, especially the endothelial cells, the pericytes, deposition of amyloid in the small vessels, as well when there's amyloid and blood-brain barrier dysfunction. I also believe that the tau pathology increases, and together they result in small vessel disease, which then appears on the MRI as white matter lesions and lacunes. And this increases the rate of incident MCI as well as progression from MCI to dementia. So this could be one way to look at the entire spectrum of vascular MCI. So this is the Dementia Research Center Singapore. We work with many hospitals. We work with the NNI, the NUH, Khoo Teck Puat Hospital, Institute of Mental Health, as well as SGH. So we have patients coming from different centers, and we do a lot of biomarker and neuroimaging work, and we give our patients a report that they take back to the various hospitals when they go and see their doctors. So in summary, I think the main findings is that we are seeing a relatively low burden of plasma as well as CSF amyloid in the Southeast Asian MCI population. The prevalence of ApoE4 is also low, only about 15 to 20%. We are seeing almost 93% of our patients having a high burden of small vessel disease. This affects their cognitive profiles and brain atrophy patterns. Among the WMH, if you see confluent WMH, that is more sinister. It results in more rapid cognitive decline, higher rates of progression to dementia. We are doing more biomarker work, looking at neuroinflammation, looking at A beta 42-40 ratio, and so on. So with that, thank you. And this is my team at the Dementia Research Center that contributed to a lot of the work that I just presented. Thank you.
Hello. Thank you for the presentation. Any question from the audience? Okay. I have question. Yeah.
Yes, please go ahead.
I wonder your ATN cohort that do you ever subjects with comorbid with the tau pathology and vascular pathology?
Yes.
And
So
how do you classify them?
yeah. So if you look at this, so you see in among our patients with CSF, there were patients who were tau positive but amyloid negative. But in this group, there were some who were also cerebrovascular disease positive. So strictly speaking, based on the ATN criteria, you cannot call them Alzheimer's disease. They're non-Alzheimer's pathology. And this is where whether it is more of a primary tau disease or primary cerebrovascular disease, it is still not clear. Because what I believe is when you have ischemia in the brain, that makes your tau go up. So we actually did a transgenic animal model experiment. We had rats, transgenic animal rats, triple AD, and what we did was we did a carotid artery stenosis. And what we showed was when you induce ischemia in the triple transgenic AD mice, the amount of tau went up, but not the amyloid. So ischemia may be driving the tau, and that's why you're seeing both tau and cerebrovascular disease.
And in terms of the CVD positive, how severe of the CVD?
Yes. So more than 44% of them have fuzzy cast grade 2 and 3. So there is a lot of white matter disease in their brains.
Okay, thank you. And Professor Chen Zhengsheng have question. Do you want to ask by yourself? Professor Chen's question is, is the prevalence of vascular risk factors among the study sample higher than that among the normal population?
Yeah, so it is common. So what we are seeing is even in our normal population, there is a high vascular risk factors. They have diabetes, hypertension. But what we are also seeing is the WMH is different. So in our patients with MCI, the volume of WMH is much higher compared to those who are cognitively normal, number one. Number two, the type of WMH is different. There are more confluent WMH in those who have MCI, and the location of the WMH is also different. We are seeing more WMH in the corpus callosum and the frontal regions. Whereas in those who are cognitively normal, even if they have vascular risk factors, they may have some WMH, but it is not confluent and it is not in the frontal regions.
Mm-hmm. How do you explain the discrepancy between the SCD and the MCI?
In terms of what? Discrepancy in...
Discrepancy, yeah. For example, the confluency of the white matter regions is lower in SCD and in an MCI, the count is
small.
almost 50-50.
Yeah. So that's why I say I think confluency is a dynamic process. So when we see more confluent lesion, that tells you that there's continuous occlusion of the small blood vessels. And that's why MCI, we are seeing more confluency. What I believe is in the SCD group, this number will keep increasing. When the amount of confluency goes up, a lot of these SCD people will go on to become MCI. Their cognitive impairment will also get worse.
Do you follow this cohort?
Yes, so we are doing annual follow-up. So far, about 100 of our subjects have come back for the second follow-up, but this number will increase over time.
Okay, and Professor Hu Chaorong also have question. Do you want to ask by yourself? Professor Hu's question, yeah, please. Professor Hu's question
Can you
is,
hear me?
yes,
I can hear
yes.
you. Yes, go ahead.
Okay, thank you so much for your excellent talk, Kandiah.
Thank you.
My question is, what do you think the interaction between amyloid and the vascular pathology? Do you think both of them are interact or it's independent?
Yeah. So I think there is definitely an interaction, and I believe that this is the level of the blood-brain barrier. So what we know is when there is amyloid deposition, the pericytes in the blood-brain barrier become affected. And when the pericytes become affected, they have become less contractile. So that then results in more hardening of the blood vessels. So the blood flow becomes reduced. So definitely there's an interaction. It may be at the level of the pericytes in the blood-brain barrier.
Okay, thank you.
Mhm. And Professor Li Weiru have question. He want to know that do you think that all the why-matter regions, why-matter intensity is caused by cerebral vascular damage, or maybe there are some other etiology contributed to
Yes.
why-matter regions?
Yes, that's a great question. So we are actually studying this at the moment. And I believe there are three major mechanisms for white matter disease. Number one is cerebral hypoperfusion, right? Blood flow.
Mm-hmm.
Number two is actually endothelial dysfunction. This endothelial can be at the level of the blood-brain barrier. And when the blood-brain barrier is affected, the tight junctions become damaged. When the tight junctions become damaged, then there's extravasation of toxic substances from the systemic circulation into the brain parenchyma. The second mechanism is endothelial. And the third mechanism is neuroinflammation. Again, through the endothelial barrier breakdown, more inflammatory matter go into the brain, and that affects the entire white matter process. So hypoperfusion, endothelial dysfunction, and neuroinflammation may be the key mechanisms for white matter disease.
Thank you for the explanation. And Dr. Huang Likai want to ask, confront parameter change indicate existing pathology or may show regression in the cohort?
Yeah. So again, from clinical trials, what we know is over a period, like for the studies like Accord Mind and Sprint Mind, what they've shown is in a period of 3 years, almost about 45% will have an increase in WMH. About 50% will have WMH stable. 5% actually the WMH goes down, decreases over time. What causes the WMH to go down is where the question is. We really don't know yet. Is it blood pressure control? Is it medications? So that is where we are trying to focus to understand what makes the WMH go down or regress over a period of time.
I believe it will be interesting to
Yes.
compare the longitudinal study about
Yes.
the conference parameter regions.
Yes.
Yeah.
How do you all see a lot of white matter disease in Taiwan?
Yeah, yeah. I believe it is quite common in Asia.
Yes.
Mhm. Not only in Southeast Asia,
Yeah.
it is also in North Asia.
Mm. Yeah.
We saw a lot of patients with why-matter regions in Taiwan. Yeah.
Yeah.
And
And
Professor Chen, uh, uh, well, have a question. Can you explain more about MBI? How to define the positive of MBI?
okay, so MBI, we now use a MBIC checklist, MBIC. So it's a freely available checklist where there are 5 domains. different 5 domains that you look for in terms of behavioral changes. And for each of these domains, you have different questions. So you should look up the MBIC checklist, and these are the 5 domains that they look at: motivation, regulation, and so on. What has been shown is if you have MCI and MBI, the risk of progression to dementia is almost 25%. Whereas if you have MCI alone, the risk is about 15%.
Do you have the prevalence of MBI in your cohort?
Yes. So you look at this, actually it's quite high. Depends on how you define MBI, whether you need 1 or more. There is no consensus at the moment. But a lot of our patients, almost 40 to 45% of them have some behavioral changes, and that will qualify for a diagnosis of MBI. And I also believe that this may be related to white matter disease, because white matter disease affects the frontal part of the brain. So that is where your behavioral regulation is also there. So maybe we're also seeing a lot of MBI because of the white matter disease in our patients.
Thank you. And Dr. Li Weiru, hope you to further specific which kinds of neuroinflammations leading to white matter lesions.
We don't know yet, right? We don't know. There are many different neuroinflammatory markers. One of the markers that we're interested in is actually the TNF beta, because there are some studies to show that there are some changes in the TNF pathways that may actually be directly controlling phagocytosis in the blood-brain barrier. So that is something that we are looking at, but we are studying interleukins, many markers we are collecting at the moment.
Professor Hu, would you please ask by yourself?
Yes, my question is that regarding the vascular cognitive impairment, do you know any potential treatment beyond the stroke prevention?
Yes. So there are a few potentials. So number 1 is therbonine, right? Therbonine, which is ginkgo biloba extract. So if you look at their work, they have shown that therbonine actually reduces viscosity and improves microcirculation. So therbonine, and we now have a consensus paper in Asia to show that therbonine is useful for MCI, especially vascular MCI. The other one is sovernate. Sovernate is phosphatidylcholine. Again, because of the sphingolipids in it, it improves the blood-brain barrier function, and hence it may also reduce the vascular MCI. Now, the other drugs that may be useful is those that are being used for diabetes, your SGLT2 inhibitors, like empagliflozin. Again, there's some evidence that they may be useful in reducing white matter disease.
Professor Kandiah, because you are the chairperson of the clinical practice guideline on dementia in Singapore, I'm interested about the content of the practice guideline. Do you have the regulation for the imaging study or the biofluid study?
Yes. So, so what we have done is we have included CSF as a test that should be done or recommended to be done in people who have young onset dementia. So we have included CSF as one of the criteria or the guidelines for young onset dementia. And also for, as usual, for rapidly progressive dementia. So I think that is one of the major changes. Other than biofluids, for MRI, we recommend that for people who have MCI or mild dementia, that they have an MRI. Whereas if it's moderate to severe dementia, a CT scan is good enough.
Do you ever find the rare disease from the CSF study in young onset dementia?
Yeah. So we have a few. We have, of course, other than CJD, we have found cerebral amyloid angiopathy with inflammation, CAAI. So we have identified a few patients with CAI using CSF and MRI, because the MRI will have a lot of tumor-like white matter, and then when you do the CSF, there's some suggestion of inflammation. So it is useful in the younger onset patients.
Uh-huh. Do you have regulations about the genetic study in Singapore?
Yes. So not only for dementia, now the Ministry of Health have come up with some general genetic testing guidelines. Who can be tested? You need to do pre-test counseling, post-test counseling. So this was, I think, published last year under the Ministry of Health genetic workflow. So we have some guidelines on this.
Mm-hmm. Okay, but I also wonder the prevalence of ApoE4 in Singapore in
It's
general
low.
population.
It's low. It's low.
Uh-huh.
Yeah. So even in our community sample, we are only seeing about 20% positivity.
Uh-huh. Okay. In Taiwan, the old study is 7%, but
7%. Wow.
currently we think it is for 14 to 16%.
Yes. So that's very interesting, right? Because in Asia, that means we are seeing a lot of very low E4,
Mm-hmm.
right? And in the West, it is the opposite. So a lot of the disease-modifying drugs like your lecanemab and so on may not be very, very useful for our Asian population because of the low E4, low amyloid.
In terms of the E4 candidate, it is estimated to about 1% in Taiwan.
Mm-hmm. Yeah. So in our cohort of about 600 subjects now, we only have about 8 patients who are E4.
Uh-huh. Okay. Any other question from the floor? Okay, if no further question, then thank Professor Kandiah for his excellent talk. We hope we can invite you in the future.
My pleasure. Thank you for inviting me. Thank you.
Thank you.
Bye-bye.
Bye-bye.